Good morning. How's everybody? Is this your normal attendance? Yes? Okay. Today we'll be having an overview of what you probably had last year and a little bit more. I like always to do some correlation between what we talk in the basic science and have some clinical correlation. So we're going to start with looking at a case, and this case was published in the New England Journal of Medicine, and just to see that what we are learning on the basic science level is important as we look at patients. So we're going to go quickly over the skeletal muscle structure and function review, skeletal muscle fiber types, neuromuscular junction. We're going to talk about excitation, contraction, coupling. And finally, we're going to go back to the case and try to see how things unfolded with this patient. So just take your time, read this case, and when you're done, just raise your hand. I'm going to go quickly over what you already know. So this part, I'm going to just be asking questions. And I like, just to, some reactive class here. Okay? So, what are the differences between those muscle types? Skeletal. Yes? Scott, go for it.
Well, I can speak histologically because I attended a lot of your sessions last year.
Okay.
The nuclei.
That's the least I expected. Okay, that's the least. Okay.
The nuclei are in the periphery.
Okay.
So that's one thing you'd notice versus cardiac muscle, which is going to be in the center.
Mm-hmm. How about smooth muscle? Where's the nuclei located?
Those are also in the periphery.
No, they are central.
Yep.
Okay. Okay. So, structure-wise, you know that. So you all know that that the striated or the skeletal muscle fibers are striated. They're multinucleated, and each muscle fiber contains these peripheral nuclei. This is a diagram to show. And each muscle fiber contains these myofibrils. These are the organelles and tons of mitochondria because of the energy that is needed for muscle contraction. Another important structure that is very specific to skeletal muscle is the smooth endoplasmic reticulum. Why is it special? Dan, come on, yes.
It's full of calcium.
It's full of calcium, yes. Its function is to store calcium. That's. Any questions so far? Nothing. It's all easy stuff, right? Okay. So, in the sliding filament theory, so what am I looking at here in this machine-like structure? Yeah, so this is a sarcomere on both sides, the Z lines here, and the actin filaments, and then the myosin filaments in the middle, and this is the M line supposedly. Reticulum. So we know here. So this is, if you can imagine that this is the cell membrane, and this is the T tubule here. On the other side, on each side of it will be the sarcoplasmic reticulum. This is the terminal cisternae. One on side here, this is the DHP receptor or dihydropyridine. It's the voltage channel that function as to block this receptor on the sarcoplasmic reticulum. This is what we call the ryanodine receptor. So it is blocked all the time when the muscle is relaxed by this DHP receptor. The calcium voltage sensor, when wave of depolarization happens, it will just change shape and it will open the ryanodine receptors to allow calcium that is stored in the sarcoplasmic reticulum into the cytoplasm or the sarcoplasm of the muscle, and that would lead to muscle contraction. Happen Once you have the myosin binding sites are exposed, so you can start from here. So we know that the myosin is composed of a tail and a head, right? Two heads. And each head of the myosin molecule has an ATP binding site. Has other things, but has ATP binding site. So once we have this exposure of these binding sites, basically myosin will say, hey, there's a chance. So it will go up and bind to the actin. With that, when this happens, this is what we call a cross bridge. Okay, this is when the actin binds to the myosin binds to the actin. This is a cross bridge. So in this case, myosin has to be bound to ADP and inorganic phosphate. So ATP has to be hydrolyzed in order for this to happen. So as I said, myosin is bound to ATP, has to be hydrolyzed to be able to bind to actin. Once it binds to actin, inorganic phosphate is released. And with that, there will be a lot of energy that is stored in that bond that was broken from the ATP. And that would lead to generation of energy. And actin and myosin, basically the head will push on the actin molecule, causing what we call the power stroke. And when this happens, both actin on both sides will come to the middle of the sarcomere. After that, ADP will be released. And here you have myosin will still be bound to actin. This is very critical. For myosin to be released from actin, ATP has to come again and bind to myosin. Why? Because this will be the only way for myosin to become detethered from actin. And the process is going to be repeated. ATP will be hydrolyzed by an enzyme called the ATPase, and the process will be repeated again. So, any questions?
How much ATP does this cost us?
It's So, what do you think, Joseph? You don't ask me and then go on your phone. Can't do that.
Well, I just broke the microphone. I've heard multiple things. I have a theory of my own, which you may or may not want to hear. Something about 1 ATP.
1 ATP per molecule?
Yeah, but that's not considering initiation and then also de-initiation or what?
So you start with ATP, and then ATP is gone. And then you need another molecule of ATP for the process to start again. The process does not end here. You need that too. You need that. Okay, so videos. So, any questions? Good. Another. Okay, so briefly back to this case. Remember that woman came with a predominant symptom was pain, swollen and tender muscles. And we talked about compartment syndrome, but so the treating physician, they said it can be because there was no trauma, no lesion, no infarcts, no obstruction, no DVT, no vascular or neurological findings in this woman. So we talked about myositis, and actually it can be myositis because of the amount of pain. And what else? So this patient was taken for a chest image, CT scan, and we can look here at her chest. So this is the heart, right atrium, and the had 3 differentials, either a thymic neoplasm or lymphoma or a thyroid tumor. And basically what they did a needle biopsy, and they found that it was a thymoma. So So you know that the thymus and its role in controlling or in doing the immune tolerance, whereby the T cells that are reactive to our antigen or self-antigens are deleted. It's not really known why, at a certain age in certain individuals, this mechanism fails with the enlargement of the thymus gland. Some of the antibodies that are generated. So they did a biopsy of the deltoid muscle, and you can see here the muscle fibers look very strange. There's no skeletal muscle. That is very atypical. Central nuclei. When you see central nuclei in a skeletal muscle, you know that this muscle is being regenerated. So there's some active regeneration happening. Lots of my inflammatory infiltrate. This is a Mason trichrome stain showing a lot of fibrosis, antibodies development. So it was funny that after they did this biopsy, the woman was released out from the hospital, and then she came back with exactly the symptoms that she was asked about. She was asked about if she has dysphagia gravis. When you see the patient with ptosis, this is almost virtually diagnostic, and dysphagia. And you know about myasthenia gravis that basically the postsynaptic membrane loses its folds and the number of the receptors is reduced because. So basically, the woman was given pyridostigmine, which is acetylcholine esterase inhibitor, to allow for the acetylcholine to work on the receptors, and also glucocorticoids to reduce inflammation. This video here is showing you a patient with myasthenia gravis to see what does it mean to have this gravelly voice and how does it start. Okay, so I'm going to leave this question for you. It's easy. But we talked today about the skeletal muscle structure, red and white muscle fibers, the contraction, the myneural junction, excitation, contraction, coupling. Talked about the calcium ryanodine receptor, talked about summation, recruitment, isometric, and isotonic contraction, and we talked about myasthenia gravis and myositis due to thymoma-related autoimmunity. Any questions? All right, guys, thank you.